after our, all right, everyone, thanks for joining us after the lunch break. We appreciate that you made it here. My name is Birju Patel. I'll be hosting for the next hour. I'm an internal medicine physician and a clinical informatics fellow. My research is in the space between clinical decision making and data science, and I benefit from all of these Starr tools. So I suspect, like many of you, you're thinking about how to leverage these data sources to the fullest extent possible. So welcome to this panel. We're going to talk about the successes, challenges, and barriers of linking multimodal clinical data. This topic has come up a couple times earlier in the morning. And so we'll get to explore it a little bit more in depth right now. Some house rules. So this is, I think as Nigam had commented before, this is an in-house conversation and we want it to be interactive. So we can't do it in person, but we do really want your participation. So feel free to ask questions in the chat. Otherwise, I'm naturally just gonna take over the conversation. I'll ask all the questions that I want to ask, but feel free, we want to make sure we get your questions answered. Priya will monitor the chat and she'll ask your questions at the appropriate time in the flow of the conversation. So just want to step back and think, why are we talking about multimodal data? And I think the big picture is that we want a more comprehensive assessment of the patient. Well, what do you mean? Like, isn't Starr OMOP everything? So I think of it in a few major buckets, and this is not comprehensive. But one is all of the clinical data. So we think, okay, well, if the patient went to the hospital, that's going to be all the data that we want. We want to know what happened there. And isn't that just an Epic, our electronic health record? Well, that's not really the case because the lab has its own IT system. The radiology department has its own IT system. The financial records are also kept separately from how clinicians interact with the clinical data. But there's also a couple other major buckets that we're not even talking about yet. So patient data. So if patients have sensors or if they have patient-reported outcomes, what system keeps track of that data? Or where at Stanford, we have basic science labs, right? And so they're producing research data. Well, how do we connect all of these different data sources together to come up with new insights? And why do we do that? Well, why do we want to do that? Because we want to make some groundbreaking research, right? This idea of precision medicine requires a more granular picture of who the patient is and what's happening to them. And we want to do it here at Stanford because we have the competencies to do big data well. So of all the people to tackle this challenge of connecting all of this data and making meaning from it, we hope that we can do it. I lost all of the video for everyone else. Is that intentional? Everyone?
No, you're spotlighted for everyone else. That's
okay,
why.
Cool. All right, thanks. And so today we're going to talk about why that might be hard to do, linking multimodal data, and what we can do about it to find some success. So as I introduce each of the members of our panelists, we have 5 today, I'll ask them to share, spend a few minutes to share their experience in the space, and then we'll dedicate the rest of the hour to actually time for interaction and discussion between them.
So good, yeah, perfect.
Okay, great.
Oh, we see you now, yes.
Okay, great. All right, so I'm going to start with David Schenker. David is the Director of Systems Design and Collaborative Research at the Stanford Lucile Packard Children's Hospital. He's the founder and director of SURF Stanford Medicine, a group that brings together students and faculty from the university with physicians, nurses, and administrators from the hospital to improve the quality of care using operations research. He received a PhD in theoretical math from the University of California, San Diego under Jim Agler. Before coming to Stanford, he was a joint research fellow at the MIT Sloan School of Management and Massachusetts General Hospital. His current areas of research include applications of operations research in healthcare, healthcare policy, mathematical control theory, and functional analysis. He advises Carta Healthcare, an analytics company started by former students. So I've had the benefit to hear you talk about your projects using multimodal data before, and I really enjoy how honestly you discuss your successes and challenges in this space. Can you share with us some of your highlights, David?
Thank you. Thank you very much for having me. It's an honor to be here. And for the kind introduction, I see a lot of familiar faces in the audience. Great to get a chance to speak. And yeah, actually, we recently wrote a paper in which we were even less diplomatic than you were, that we called Successes and Failures. And I think it's incredibly important to be upfront about the failures. Certainly, they don't make it into publication as often, but if a single center success is not generalizable, I think a single center failure may be much more generalizable, since issues that lead to failure in one place will likely lead to failure in other places. And so I'll just give two examples. One was we wanted to use physiological waveform data to try to identify earlier on warning signs that a cardiovascular intensive care unit pediatric patient may be deteriorating. There were some hypotheses from our clinical partners, particularly Dr. Andy Shin, the medical director of SURF, that there are signs leading up to these kinds of deteriorations that result in a code blue or rapid response. And we had fantastic physiological waveform data at something like 125 readings per second that a PhD student spent years cleaning, analyzing, and turning into a usable format. But we were unable to link them to discrete patient data as well as patient outcome data of the kind we were interested in. The purported data set of rapid responses we were going to use did not align perfectly with the time frame for which the data were available for the patients, and the much broader kind of set of clinical events we had hoped to get access to just was too challenging technically to link to the data we had. And that was a project where we actually just abandoned our initial ambitions to try to identify actionable risk predictions, and instead focused on building neural network models that help improve the quality of the data or help try to estimate blood pressure, which is usually measured invasively through an arterial line, through the non-invasive channels like the respiratory and the cardiac data. And we made some progress there. So that was a nice example of an initial failure because of just the difficulty of linking messy multimodal data sets, and then a success from the point of research of focusing on something intrinsic to the data, which we by definition had. And then another project I'll mention briefly, it also kind of reflects the scope of our work, was trying to reduce errors in our surgical supplies and then measure the impact of that error reduction on costs, which involved not just clinical operational data and surgical supply data, but also financial data on top of the time-stamped procedure events so that we could understand what something cost when, and then patient outcome data for afterwards to make sure that our intervention and our attempts to improve surgical supply accuracy didn't have any kind of deleterious downstream effects on, let's say, length of stay or readmission to CVICU. And that was a project where that was, again, a massive data undertaking, but that actually did succeed, in which we were able to reduce costs without seeing any kind of adverse events in a primary analytics-driven way. And there, really, the vast majority of the effort was on linking the data sets to what we were interested in doing. And then the analytical component of the work was pretty easy by comparison to that initial effort.
That's great. Thanks for framing it with a failure and a success and a learning opportunity, to be honest too, right? So I was going to introduce next Elsie. Elsie Giang-Ross is a vascular surgeon and a research scientist. She graduated from Stanford University School of Medicine in 2011 and completed her vascular surgery residency at Stanford in 2018. During her residency, she completed a 2-year postdoctoral fellowship in biomedical informatics. Her current research focuses on using machine learning and electronic health records for early disease identification, precision medicine, and evaluating opportunities to engage in patient education beyond the clinic. And we benefited actually from hearing a little bit from of the research work in Elsie's lab at the spotlight sessions just before lunch. Elsie, I know you know firsthand how much work it takes to generate and connect multimodal data. Can you share with us some of your experience in a recent project?
Yeah, so to give some context, I started on faculty in 2018 and have this K grant that's allowing me to develop into an independent scientist. So part of that is trying to figure out how to build, quote unquote, my own lab, how do I get data, how do I link it to push forward projects that are different from the lab that I came from. And I came as a trainee in Nigam Shah's lab. So it's kind of hard to move from underneath that bright spotlight. But one of the things I'm interested in, partially through collaborations, is how do we link genetic data to EHR data to improve detection of disease and predict outcomes. And so we're at Stanford, Dean Minor is beating the drum about precision medicine. And so I thought, okay, I'm gonna link the genetic data to the EHR data for vascular patients. So we have Gene Pool, which is a project that has been going on for quite a long time, where patients who came to Stanford were consented to give some of their genetic samples somehow, whether there be blood or oral swabs. And so I knew of it. I didn't really know what the data consists of, but I knew that Gene Pool existed. So I'm like, okay, I have the EHR data. Now I just need to get the genetic data. So I go to the Gene Pool researchers and I'm like, hey, can you give me the genetic data on all of these patients in Gene Pool? And they're like, we've got samples that you can genotype. and so then it became a completely different mission, because although I had been working to understand like how you develop genetic risk scores, I had never actually pipetted anything to then give to a lab to genotype. And so that kind of shut down the project for a while as I tried to figure that out. Thankfully, one of my mentors, Nick Leeper, runs an illustrious lab with, a lot of basic science people research assistants and the such. And so I kind of go to Nick and I'm like, hey, can someone in your lab help me pipette? He's like, sure. So I get the samples, I talk to someone in the lab, and then the other portion of this that I'm not even talking about is figuring out how to get these samples genotyped. Stanford has a service, but it's quite expensive. I didn't have that much money. I found another lab that's in Santa Clara. Finally, someone's able to help me pipette. I get the samples, and then I have to figure out dry ice. Thankfully, they have dry ice. And then I literally get in my car, take the samples, get in my car, and drive it down to the lab. And I'm hoping that, the results will be fruitful and be able to, say something about genetic risk in vascular disease. But it took a long time to figure those pieces out.
I love that story. Research is hard work, and that was a physical, manifestation of that. Thanks for sharing. I'm going to introduce next Thomas Montine. Dr. Montine received his undergraduate degree at Columbia University, his PhD in pharmacology at the University of Rochester, and his medical degree at McGill University. After his postgraduate medical training at Duke, he was the Throne Professor in Pathology at Vanderbilt. He became chair of the Department of Pathology at the University of Washington in 2010. And then in 2016, he was appointed chair of the Department of Pathology at Stanford, and became the Stanford Medicine Endowed Professor in Pathology. The focus of the Montine Lab is on the molecular and biochemical bases of cognitive impairment in aging and neurodegenerative diseases. The Montine Lab addresses these prevalent unmet medical needs through a combination of neuropathology, biomarker development, and application early in the course of disease, and experimental studies that test hypotheses concerning specific mechanisms of neuron injury and approaches to neuroprotection. So we heard about Elsie's significant labor in getting some data. You were working on digitizing clinical pathology images to enable researchers to conduct studies. Can you share some information with us about this project?
Sure, thank you. Welcome everyone. Delighted to be invited to speak with you today. Thank you for that very generous introduction. It has nothing to do with what I'm going to talk about. So when I got here in 2016, there was a confluence of enthusiasm around digitizing the pathology service. So let me explain what that means. Pathologists interpret structural and molecular data from biopsy samples, right? Tissue that comes from patients. As the surgeon or the proceduralist will remove tissue, it comes to the pathologist. And then we use light microscopes to interpret biological data to make a medical diagnosis. The hypothesis is that if we were to digitize that process rather than using a light microscope, but generate a digital image of this structural and molecular information, that machine learning applications can gain even greater insight into the medical implications than humans can. That's the hypothesis. And I say there are lots of people testing that right now. I don't think anyone's proven that hypothesis yet. But that's I guess the aspiration. So what have we done to try to achieve this aspiration? So as I say, in 2016, there was a confluence of interest, and I'm proud to say that as of last year, our anatomic pathology service, meaning all biopsies, all resections that are being obtained within Stanford Healthcare and LPCH, all of those images are being digitized for the clinical service. That is an enormous amount of data that now flows through the clinical operation. And our intent, it hasn't happened yet, but our intent is that when those images are no longer clinically active, that they will transfer over to Starr. And the idea there is that we will have this unique, and I would say uniquely in the country, uniquely comprehensive structural and molecular data that then can be linked with the other rather deep annotation that exists within Starr. So our role in all of this great work that you're doing is to generate novel data that will get exported to Starr. The challenges we face is, what do we export? Do we export all of it or some of it? And related to that is, how much memory are we willing to commit to this? These are very large image files. So what do we export? Once we decide that, how long are we going to keep it? How accessible will it be? All of those questions, we're going to rely on you, the users of the multimodal data, to guide the School of Medicine in making those decisions about how they handle these images as they cross over from the clinical operations to research. Thank you.
Yeah, that's great. Thank you. Next, I'm going to introduce Matt Lundgren. Dr. Lundgren is co-director of the Stanford Center for Artificial Intelligence in Medicine and Imaging, and associate professor in the Department of Radiology at Stanford University Medical Center. Dr. Lundgren's NIH and NSF funded research is in the field of AI and deep learning in medical imaging, population health, and predictive health outcomes. So piggybacking on all of this massive data that's been generated, there's actually been a lot of attention in the radiology space for their early accomplishments extracting information from these large digital images. Can you tell us a little bit about your research projects that have used multimodal data?
Yeah, absolutely. Yeah, thanks again for having me. It's great to see all of you on the panel. That's a nice group. Yeah, so from the radiology side, I think we're sort of in that place where almost all the work we do has been digital for quite some time, right? So we're very focused on the imaging component of it, right? So that we're looking at the world from everything starts with the image, and then maybe the EHR data is around it rather than the other way around. And that's kind of how the field started too, as machine learning began to play a larger role in sort of research and radiology. But as anyone who has an imaging centric specialty, radiology, ophthalmology, dermatology, pathology, we don't just look at the pixel data to make decisions, right? To do our work. And so it's very clear, as our field's progressing, as the research, objectives are changing, how do we actually start to, bring in the real cognitive work that we're doing as a specialist in an imaging space? And how do we tie that into some of the machine learning models that we're building? And clearly that's multimodal data, right? That's kind of our thing. And so, we really try to work hard on, understanding the current state of the art, what are the techniques available for what we would call multimodal data fusion. So bringing in, different types of data, but there's many different ways you can sort of put them together. It's not just an ensemble kind of approach. And so exploring that, made us realize that, for at least for the data sets that we're building here, it's incredibly important to kind of line up exactly what you need and how it relates to the imaging exam and et cetera. But one of the challenges, just I wasn't pipetting and I don't have to scan slides. But one of the things that came up for us was that clearly in our field we have an overfitting problem, just as with every other biomedical data science group. And so you really do need to do external validation, right? You need to figure out a way to decide how well your model will perform on an external data set, right? That has a different distribution of pathology and potentially different machines, at least in radiology's case, and certainly different patients. And so we wanted to link this multimodal data set that we created for the pulmonary embolism use case with a partner hospital. And I was naive at the time. I say, hey, you're on Epic, we're on Epic, we'll just pull the same fields and we'll line everything up and it'll be no problem, right? And what you start to realize is and then this is slightly before OMOP really became very big, but it's incredible amount of work, right, to organize that data set, to have even the sort of the field codes line up in any meaningful way that you can actually start to sort of line up the models. And then again, it comes down to annotation. So there's a lot of steps that and an OMOP, I think, to Starr's credit, is really going to help facilitate that, particularly for the sites, the partner sites around the country that are buying into the OMOP approach. But the challenge then, and that I'll pose to the group, is that while you can then build models with OMOP as sort of the common data language, trying to bring that back out into a translation becomes that much harder, right? Because then now I have to figure out how to get those OMOP field codes back into a format that will actually run in my Epic production system, for example, if I'm using EHR data. And certainly for DICOMs, it's a little bit easier. So while it can facilitate some of the research, and we're willing to pay that price to do that, I think now we're sitting here, successful and ready to implement, and now we're faced with this new challenge, right? So now we have this additional translation kind of spider web related to sort of bringing field codes out into OMOP and then trying to bring them back into a sort of production space for both sides. So anyway, I think those are some of the things that I'm thinking about. But then again, just in terms of translation broadly, and this is probably for everybody, we're ready to, land this plane, but we have no runway yet. Like, it really is an infrastructure question. And it's not just, can we hook all the pieces together for one modality? Can we hook them together for multiple modalities? But then beyond that, do we even have the language and the metrics to monitor these things in production? Do we even understand, we look at other fields and other verticals where, these models start to drift away, whether because of the input data changes over time or that there's technical debt that accumulates. We have no meaningful way in healthcare, to my knowledge, to actually evaluate that, right? There's some things that can work in other fields that maybe focus on tabular data, but nothing's healthcare specific. And this is critically important for us, particularly as we think about other aspects of what we do. Our overall metrics sometimes miss subpopulations, they miss subclasses of disease. We need to have a way to do that. So as I'm thinking more now in the implementation space and less so in the, idea generation, data set creation space, how can we sort of serve our needs from the beginning to ensure that this whole pipeline is ready for the researchers in this group, and certainly for partner institutions as we expand our work.
I love that. And it makes me reflect on, I think we can talk about this later, but ML ops is a term that's becoming more prevalent. But just also, this is the point of us doing it and having discussions like this, that not only are we thinking about how to connect data to do precision medicine, but also setting the strategy for that last mile of implementation of doing something meaningful with the science that we're generating. So awesome discussion points. We have one more introduction and we'll get to these questions. Tina Hernandez-Boussard. So I'm gonna have her introduction. Okay, so here we go. Dr. Hernandez-Boussard is an associate professor in medicine, biomedical data science, and surgery at the Stanford University School of Medicine. Dr. Hernandez-Boussard's background and expertise is in the field of clinical informatics and epidemiology, with concentration in predictive analytics, population health, and health policy. A key focus of her research is the application of novel methods and tools to large clinical data sets for hypothesis generation, comparative effectiveness research, and the evaluation of quality healthcare delivery. And one of the things that I really appreciate about Tina's experience is that you've been working in this space for a long time. So I'm hoping that you'll give us some lessons learned. Can you tell us about your experience in multimodal data?
Yeah, sure. So thank you for having me on this panel. As you mentioned, I've been working in this space for about a decade now. So really, we started in the very beginning. We're like, oh, we've got this EHR data. It's going to be so easy. You know, here we go. Let's go. And so now, 10 years later, we're still kind of, we've definitely moved forward, but we've definitely had a lot of challenges. And so let me start with our research question. So back, in the day, our research question was, we wanted to compare outcomes between a specific treatment in patients with prostate cancer. That was our original research question. And it's important when you think about the EHRs that we just really have a snapshot of the patient, right? We know what happens when they are in the hospital. We know what happens when they come to the emergency room, but we really don't have a comprehensive view of the patient, right? We don't know what treatments they get outside of Stanford. We don't know, if they go back to their home and have 3 ED visits. So all of that information is missing. So when you think about looking at outcomes for a treatment or outcomes for a disease, it's really not a great place to look at unless you're able to pull in different sources of data. So what we did for our project was one of the things we noticed is that a lot of our patients were getting treatment outside of Stanford. So they would get diagnosed at Stanford and then they would go home and maybe they would monitor their disease with their primary care somewhere else and only come here when they had very adverse events or very serious complications. And so we linked our EHRs to the to the California Cancer Registry. And that was, so I want to say, as others have said, it's not easy to link these EHR data with other registries or data sets. So that took a lot of time and a lot of effort. And, I was so thankful for everyone on Starr, in particular, Tina Cito, who really helped us do that linkage. And so when we link to the cancer registry, we're linking at the individual patient level. So for every patient that comes to Stanford with a cancer diagnosis, we can then link them to the cancer registry. And so then we find out treatment outside of Stanford. We find out survival information. We have histology information, a lot more information that gives us a more comprehensive view. And so that really augmented the data set that we're using. And then further along, we were thinking, okay, in this patient comprehensive view of the patient, we also need to think about patient-centered outcomes. And so that was another data resource that we then brought in to hook with our EHRs were patient-reported outcomes and, in particular, promise scores that were being regularly collected through the Cancer Center. In addition, we linked to the Stanford Cancer Registry data. And so you can see we have like 5 or 6 different resources that we've hooked or connected with the EHR data to really build a data warehouse. And we particularly focused on prostate cancer for this one project. As you know, there's a similar in breast cancer and other cancers at Stanford. But what we have is we really have a comprehensive view of the patient's treatment, outcomes, diagnosis, et cetera, for this cancer and disease that we're really confident that we have a good capture. And so, I think it's important when you think about these questions that you're building and questions you want to ask of the EHR, that they can be appropriately answered with the EHR data, right? Because again, we have patients who are sick. I always say, we capture patients who are sick, sicker, and the sickest patients in our EHR system. So we don't really know, we don't have a lot of information on patients who do really well because they stay out of our system. We don't have a really good control. So you really need to link with these other data sources to get a more comprehensive picture, depending on the question you're going to ask. And so I think I will stop there and we can move on with the conversation.
Yeah, no, that's great. And I think just so that everyone puts in their mindscape too, like we have people have very different perspectives on how they're trying to achieve comprehensive information about their patients. So this is a great opportunity for us to connect these different experiences together so that we can learn something when we're all trying to develop our own research plans. I have a couple. So one, we're gonna shift into the free form discussion. So people who are listening in, feel free to put in questions to individual panelists or for the entire group. We'll make sure we get to them. But now is my time to kickstart the conversation. So There were two themes that I sort of picked up on that I wanted to talk about. Maybe we'll hit the first and do the second one when there's time, but I'll tell you both right now. The first was thinking about the skills and people that you needed to accomplish the projects that you wanted to do. And I've heard, we heard a little bit of that in a few different stories, but I want to delve into that a little bit more. How did you find the people and the skill sets to help you link the data? And then the second is on that ML ops strategy perspective. So how do you think about the quality of the data and how you manage it? So let's tackle the first question, the teams and skill sets. And I think just because I have interaction with some of the people that you interact with, Matt, do you mind kickstarting us and telling us about the people that you needed to put together to help you do your research?
Yeah, sure. Thanks. You know, one of the things about being at Stanford is, you know, especially as we, you know, sort of maybe reach out to other groups, is that we're just we really have an abundance of connectivity and sort of a culture of just collaboration, right? And I just think that is true no matter whether it's computer science or, you know, medicine or wherever you are on campus. And I think that we're just in this great position in terms of you know, we don't need to go it alone. This is a team sport, right? This whole, everything that we try to accomplish. I think that there are those in the audience and some on the panel here, certainly, that have deep expertise in multiple areas. But I think it's sort of disingenuous to think about, you know, how you can possibly keep up in medicine and keep up in the, you know, the massively advancing sort of machine learning space, and then informatics and all these other verticals, data science. And so I think for us, you know, we kind of from the beginning just said, let's build teams. And that's kind of how the Amy Center formed as a community to begin with, is really how can we sort of serve as a home base to form these communities where, you know, a clinician has an interesting question that maybe could be answered by data science, or there's, you know, again, students, postdocs, PhD students, faculty on campus that say, hey, I've got this really interesting technique. I really would like to do something meaningful in healthcare. And those conversations happen, right? And they, of course, they happen organically. Trying to accelerate that collaboration is sort of just the point of a lot of the work that we're doing. But just to say that we found that, you know, working with, again, multidisciplinary teams, some of them, I think, forming out of just pure interest and, you know, hey, I really want to work on this thing. I noticed that you do that. But I think at the same time, you know, seeking out additional expertise. I'll put a plug in for the QSU Manisha Desai's group in the biostatistical realm. Another area where I think a lot of us are kind of, you know, weekend biostatisticians, but we certainly don't have the kind of depth of expertise that you really need, I feel like, to achieve what is ultimately going to be the bar, you know, to get some of these things into practice and to really, you know, see the impact and understand it. So yeah, so really it's again, team sport. And we are just really fortunate to have some of those resources. I think just in the last point I'll mention is just in terms of getting the data, understanding the data that's available. I think that's a service that has matured quite a bit, certainly in the last year or two with Starr, the ability to sort of generate cohorts to sort of have a nice process to sort of identify data sets and sort of drill down on questions. That's been new. And then the other piece of that, of course, is the de-identification aspect. So it does take the burden off of a lot of us on the research side, and certainly our teams. We don't need to necessarily have a fully formed, you know, data scientist who's mining the data for us, right? This is really becoming a bit more of a partnership that's acting more like a service, allowing us to focus a lot more on the science.
That's great. I'll let any of the other panelists jump in too, but I do want to actually piggyback on that de-identification part, because Tina, you actually had an article that mentioned the idea of multimodal data, and one of the risks was that if the data was all de-identified, then it might make it harder to link it, right? If you came in with your own external data set. Do you have thoughts on that?
Yeah, and so that's true. And so there's 2 points to I think that conversation, right? The more we're linking data and pulling these data together at an individual patient level, the higher the risk is for identifying who the patient is, right? When we start linking our cancer patients and we're looking at their zip code, or they're looking at their county, we're looking at their education level, we're looking at all these, it becomes much more of a data security issue and becomes much more identifiable. But on the other side, when we use de-identified data, and de-identified data, sometimes we can have dates jiggered and things like that. It makes it much more challenging to link to other resources, and so it's really a balance between making sure the data are safe and secure, so that we are being aware of patient privacy, et cetera. But on the other sense, we need to have enough information to link to these outside data sets. And so it really is a balance between both of those. And so, when you think about that, I think it's really important that team science, as Matt was just saying, and having the right stakeholders involved. We always have somebody from, the IRT on the team, or somebody who can help us think through the data issues. We're constantly in touch with privacy at Stanford to ensure, what we can share, what we can't share. And another piece of that to think about is, more and more journals are requesting that we share pieces of data, or that we share our, some type of data set. So all of that needs to be really thought about in relation to privacy and having the right team available, because people can take that data and link it to all other types of information. So I hope that gets at your question.
Yeah, no, I think so. And if anyone has any experience thinking about the kinds of skill sets that you didn't have on your team already, but needed to collect to be able to do your research projects, let me know. Be happy to hear about that. I think for the sake of the audience learning, okay, well, this is the team that I currently work with, and this is what we do know how to do. We know maybe perhaps how to do EHR data, but I dive into genetic data. I mean, Elsie, do you want to share about how did you tackle that, and what did you learn about how you manage wet lab data?
Yeah, I would say that a lot of this process is just learning on the job, and then reaching out to more senior mentors to figure out how to put pieces together. And I think that's helpful, especially if you have mentors who have octopus arms and are constantly in touch with a lot of people across the enterprise. But for me, I came from an informatics background, specifically on clinical data sets. And so the genetic piece wasn't there, but I just had this optimism that I could figure it out. Like, oh, I can, build a genetic risk score. It'll be fine. It's just a data science exercise. And then I figured out it wasn't. Thankfully, though, I was working with a postdoc who actually had more of the genetic, how do you analyze genomics, single cell, RNA-seq, all that kind of stuff. And that really saved me from having to spend a year doing a deep dive into how you analyze this data. Also, that though, I worked a lot with the research informatics group just to figure out, what samples in gene pool can be linked to the EHR data. And so again, working with groups of people who are in the know about how to link the data is extremely important as well. And then finally, just sending cold emails to people. That works really well at Stanford. I no longer take offense when people don't answer me because, people's lives are busy. Maybe it takes, a couple emails, maybe it takes a phone call, but usually you can find someone who has enough information to get you to the next step.
Yeah, it does remind me that doing multimodal research makes you cross-disciplinary. And so it really benefits us in this academic environment where we have people who are at various stages of their training who have different tools in their toolkit.
And I would say the other thing I would add to people who are, in the beginning stages is to not feel like I did, which is, oh, I'll just learn how to do this genetic analysis. It's there are enough people who are experts that just partner with them. Don't do it yourself. It's going to take you way longer.
Yeah, awesome. I do want to shift to, go ahead.
Yeah, I was just going to add one thing when you think about that, the skill set of the team, because as Matt was saying, and we're kind of in the same place, the ultimate goal is really to bring this to point of care. So when you're thinking about building that team, you need to be sure you think about, who's going to help you get that at point of care, who's going to be the hospital support staff, who's going to be the clinical integration staff, how are those people, and they should be involved in your project when you're getting started, right? It's not after you have a fully developed model, you're going to go to hospital administration and say, hey, I've got this really cool model, I want to deploy it, in the ED. And they're like, well, no, So really thinking about that team at the very beginning is helpful, and it saves a lot of time and efforts.
Yeah, for sure. And I wanted to think a little bit actually about the ML ops perspective. And I'm going to leverage the fact that David Schenker, you're our operations expert. So you should be able to solve this for us. But actually it touches on a lot of different people's projects in different ways. So maybe, Tom, do you want to tell us about, you mentioned, there is so much to digitize and not all of it will be high value. And the people who know what things will be valuable are probably the pathologists. So we can't all, tap on the shoulders of each of your pathologists and ask them, hey, is this slide going to be meaningful or not? So what are how are you thinking about this?
Well, I say that I'm not sure that I agree with you. So we know, based on our current medical knowledge, what is medically useful in the biopsy. But the whole point, one of the points of doing this is that machine learning will unlock new insights. So I think we would limit ourselves if we said, well, we're only going to store and curate those images that a priori we know have medically useful information. I think that defeats the whole purpose at the beginning, right? Because I think we're trying to test this hypothesis, right, that ML will unlock novel medical insights. And I think there's all sorts of examples in ML applications in other fields where that's happened. So I think it's reasonable to expect that that will happen in medicine. So I don't mean to argue with you, but I think that is going to be the problem, right? It's easy to say store everything and we'll sort it out, but that's very expensive. And in fact, the size of the images, the amount that you have to sort through then, if you take that approach, is limiting. So I think it needs to be a balance somewhere between what we already know is medically meaningful and what we, are suspicious is the high likelihood additional medically valuable information. And I'm not sure where to draw that line. Personally, at the beginning, I would be more generous than restrictive, but really push people at the beginning to test this idea that, the adjacent adipose tissue to carcinoma might contain valuable information that, so far pathologists have missed, right? And because if it doesn't, then all right, we can stop storing those images. That, for example, would save us a lot of time and effort. So I think it's in between somewhere. And I imagine it'll be like that for other fields where the hope or the expectation is that applying ML will give us new insights. I don't think we want to limit ourselves to the a priori knowledge.
Yeah, I totally makes sense to me. It doesn't make sense to collect data that just reinforces what we already know. We need to expand our knowledge for new science.
Otherwise, then what we'll limit ourselves to is, can the machines perform as well as humans? Which has advantages once that can be built, because it allows us to export expertise to parts of the country and parts of the world that don't have that level of existing medical expertise. But it would completely abrogate our ability to test this idea that ML can give us new insights.
Yeah, great. Nigam has a question. If you want to unmute, you're welcome to ask it.
Yeah, no, thank you. Given that we have such a breadth of diversity on the panel, people having dealt with multiple kinds of data, what are your thoughts on how we partner with the health system, the clinical enterprise,
for prioritization of ML ops, or even treating data as a key asset and not as a byproduct or secondary use, as our keynote speaker also said we shouldn't do? Like, what strategies would you recommend we pursue as a group to get to that state?
So I was hoping to chime in both to a lot of the themes that were raised earlier, and I think in the context of Ningham's question, there's this recurring question of what's the right team, or what's the right question to answer, what's the right deployment, what's the right infrastructure for that deployment in a healthcare institution. And all of these questions, they belie the overwhelming amount of uncertainty, and not just uncertainty in like the core scientific hypothesis or mechanism you're investigating, but a much broader set of uncertainty. And in Silicon Valley, we'd be remiss if we didn't take a little bit of a lesson from the software companies that have succeeded so wildly in some ways where healthcare wishes we could succeed. And there's this notion of, if we're going to develop some kind of analytics-based intervention or improvement to care, it's going to be deployed as software. So it's not an unreasonable jump to conflate the two a little bit. And I think there's this framework that they've thought a lot about, was waterfall versus agile, where this waterfall framework is based on a really well-defined goal, really well-defined objectives, a structure, and then just one step following naturally from the last until you have something deployed and sustained and maintained. And then the agile approach is instead to constantly be iterating, constantly iterate and refine what your goal is. Iterate, refine what your team and what your team's capabilities are. Iterate what your specific deployment mechanism or the value you're trying to create is. And I think a lot of the themes that people have come up with are just that your initial ideas about what you were going to get access to, what it was going to help people do in practice, what kind of problems are going to answer, turn out to change drastically during the project. And so I think one key is, if we step away from some of the traditional things in medicine where you have this large randomized controlled trial and you know exactly what to expect, if it's a good result or not, and deviations from design are seen as a flaw, if you instead embrace this up front, and more importantly, communicate it to all of your institutional stakeholders and partners, this kind of uncertainty, this kind of need for an agile formation of the team or formulation of the process, so that as these projects go, they'll hopefully have a chance to be designed adaptively enough that they can provide value in practice, and that they're not going to seem to people ad hoc or unprofessional or somehow risky by the standards of healthcare, but really from the outset be framed as like, no, this is one of the inevitable consequences of doing something new and challenging in the presence of uncertainty.
Yeah, I love that. Yeah, reminds me that there are things that we can learn from parallel streams in industry, just different mindsets that we can take. Yes, if anyone wants to chime in on that, you're welcome to, but maybe I can also shift to another question I had about the resources and costs of doing all of this. So one of the things that we talked about was the data and storage and memory. And so if people have some thoughts about, how have they managed these potential costs, especially for their funding structures, or how did you even right size, your compute ask? Yeah, if anyone has ideas about that, because that has been a theme.
Yeah, I can go ahead and start with that, because we have built a lot of infrastructure pulling in all of these different data sources. And I think it is very costly. It is very costly to link these data sets. It's costly. You need to purchase time from people in the data center, in IRT, in your team. And it's important to also know that NIH generally doesn't fund infrastructure grants, right? And so that leaves us at this point where it's very hard to find funding to develop the infrastructure or the framework. And that's why it's really important that, you know, Starr and OMOB and these resources exist, because not everyone is going to have or be able to get the funding to develop just the basic foundation. But even taking what they have and developing your own research sort of portfolio is costly. And so it's important to really seek out internal funding that might cover this. Looking beyond just RO1s, there are a couple of infrastructure grants that exist through NIH, but it's not the typical pathway. And so, you know, if you think something's going to cost $20,000, assume it's going to cost $100,000. You know, it just is. And I know that Elsie can really speak to that very well, because she's had a few of those surprises. It is very costly, and so it's something that you need to consider when you're, and that's why partnering with other people is such a good opportunity, because you can share resources, you can share funding structures, etc. So, but it is a costly endeavor.
Well, thank you. I'll just add that we need to keep in mind the cost that it takes, if we're talking about clinical data, the cost that it is incurred on the hospitals and the clinical operation to generate that data, which is real. And just for the digital pathology example, I mean, that's somewhere between a $10 and $12 million investment made over multiple years, but that was a large investment by the healthcare system to digitize the anatomic pathology service. And as someone was saying before, what we're trying to avoid is that it remains only on the clinical side, right? And transfer that data over to Starr so researchers can use it.
You know, this is Michael Hollis. One comment I might add, one of the foundational principles of Starr was that we wanted to have it be a community resource where obviously the institution invests in the infrastructure, but also that the research teams themselves contribute into the infrastructure and the data for the greater good. So in a way, you know, we've been talking a lot about team science. If we can sort of make a mental shift to team infrastructure, because sometimes, you know, this infrastructure is created under the umbrella of a grant for a specific project, but could be used more broadly and repurposed in a generalized way. So I think, you know, if in your projects you are creating infrastructure that you think could be repurposed, it may be low-hanging fruit for the institution to add in a little bit more and make it generally available. So something to think about as you go forward. And if you have things that you're working on that you think fall into that category, certainly let us know, and we would love to talk about that.
Yeah, I think that's a great point. I think there were even some examples that were highlighted earlier in the day about that. So yeah, exactly. One of the other things that I was reflecting on when we heard your introductory stories was about the challenge of making sense of the underlying data. And I'm curious how people have explored that. You know, the newest AI might be able to find new insights. And actually, just as you were mentioning, Tom, the adipose tissue, I think I saw that published just a couple of days ago. Adipose tissue for colorectal cancer was a new feature that may not be recognized by most pathologists. So the opportunity to learn something new using machine learning, but also not relying on it if it doesn't interpret the data correctly. So how do we balance that, or how have people tackled that, learning from the data versus injecting domain knowledge and the resources needed to do that?
I mean, I'll mention that, you know, when we sort of think about just, we haven't necessarily want to pull a data set, maybe it's based on imaging, and part of the work obviously is, well, a lot of the work is really curation, annotation, right? And sort of trying to set up the problem. And if we approach this as we're going to annotate at the study level, we can annotate at the, multidimensional imaging slice level, or we can actually literally draw, ROIs around different, segmented pathology that we are trying to supervise the model to learn. I think that if, for example, in the use case you're mentioning, if you had to approach that problem with, you're going to create a causal supervised model that's only looking at the things that the pathologist thinks is interesting, you would miss that. right, you would potentially have missed that opportunity to learn from that feature. So I do think that there's ways in sort of data curation and setting yourself up for a project that you can potentially get other learnings out. At the same time, our ability to interrogate these models is suspect, and the sort of saliency maps and some of the the grad camps, the pixel-based attribution methods are not a state of the art, or not where they should be for a lot of, at least in the medical imaging deep learning space too. So we always take a lot of that with a grain of salt in terms of where the model's focusing. But I think looking at the failure cases is helpful, and sort of trying to drill down on exactly what's necessary to sort of get to the objective at hand. And again, like you said, maybe they're learning from other features. And I think about when multimodal data, it's not just the other features that you're putting into play, but it's also the interaction of those in a multidimensional space that we probably can't comprehend completely, right? So that then when it comes down to deployment and explainability and trying to figure out where things are going right or wrong, it does add a bit of challenge. I mean, there's a price to be paid for superhuman performance if we can't understand why it's able to do that, right, in a given circumstance, and then regulating that, deploying that, making sure that that's safe, ties back into the ML ops and the value proposition, exactly how we do that.
Great. David, do you want to wrap up for us?
Oh, another really complementary area is really honing in on the decisions that the care providers and the clinical context are making around the thing you're interested in affecting. In a recent project, we were trying to figure out if pediatric patients with heart block would resolve or not. It was a really hard prediction problem until we realized that it wouldn't lead until actionable decisions until several days in their CV ICU length of stay, at which point sufficient data had aggregated about that patient that it became a far less technically challenging problem. And so in general, the conceptualization of a diagnosis or prediction may differ from the explicit decision about patient care that's going to be made, and they offer opportunities either to use more data or to make a slightly different kind of decision.
That's great. So I'm going to just do a quick summary of the things that I learned. So thank you all for participating this past hour. So five points that I just jotted down. So the first is that it's costly. So it requires some money, it requires people, it requires time to be able to link this data. But the second is that it's a team science. So, the different disciplines and the opportunity for something that's really cross-disciplinary at a university like ours is incredible. And the third is that this is an opportunity to find new associations that you can't with individual data elements on their own, right? And this is relevant to generating new medicine. The fourth is that if you produce something that's worth sharing, let's share it, because team infrastructure here is really important and we can help our peers within the institution. And then the last is to consider what is that overall strategy for implementation and impacting care. So partnering between science and clinical medicine. And so we'll continue thinking about strategy. I didn't have the hope that we were going to be able to do that in an hour to be able to solve the strategic problems, but I do really appreciate all of the points that everyone's made. I am grateful for being able to host for the past hour. I'm going to turn it over to Priya to let us know what happens next.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.